Hello everyone, welcome to Patho Excellence and welcome back to our Histology for Histopathology series where we follow one simple principle, know normal to diagnose abnormal. Today we begin one of the most important organs in GIT pathology, the stomach. So before we can confidently diagnose gastritis, intestinal metaplasia, dysplasia or carcinoma, we must first master the normal histology. So in this lecture, we will explore the microscopic and ultrastructure anatomy of the cardiac, fundic and pyloric mucosa, understand the different gastric glands and cell types and learn how structure relates to function. And by the end of this session, you will be able to recognize normal gastric histology with confidence and build a strong foundation for interpreting gastric biopsy specimen. So let's get started. So topic outline include anatomic regions, layers of the different anatomic regions, cell types and different types of glands. So now first of all, what is the gastric function? So there are four major functions. First is reservoir, which stores food after ingestion. Second is mixing. So mechanical churning converts food into chyme. Digestion with the help of HCl, pepsin, and fourth is protection, which is with the help of mucosal barrier against acid, pepsin, and microorganisms. So if we see gross anatomy, first of all shape. So it's a J-shaped muscular sac which is having four anatomical regions. So this region called cardia, fundus, corpus or body and antrum. And this is located in left upper quadrant, highly distensible, and there are having two curvatures. One is lesser curvature, which is superomedial border, and second is greater curvature, which is inferolateral border. Now see, this is the diagram where you can identify this is esophagus, GE junction, this is cardiac area near the GE junction, this is fundus, corpus which is the body of the stomach. Here you can identify greater curvature, this is lesser curvature, this is called incisura, pylorus pylorus which is attached to the duodenum, and before the pyloric end you can see here antrum. So this is how you can see there are different areas in the anatomical region in stomach. So here you can see this is the cardia where this is the junction where esophagus is attached. This is the fundus, large body part or corpus, antrum and pylorus. This is lesser curvature and this is greater curvature which is broad and convex having inferior aspect. Now if we cut open the stomach, there are different mucosal zones. So this is here you can identify cut open stomach. This is esophagus. Here cardiac mucosa distal to the lower part of esophagus. Pyloric mucosa which is a triangular zone proximal to duodenum, and here this is fundus which is having oxyntic mucosa. So in microscopy you have to differentiate three types of mucosa in stomach. One is cardiac mucosa, pyloric mucosa and oxyntic mucosa. So all these three zones have a different histology. So whenever you get biopsy, you will have a different histological morphology, so that you can identify whether this biopsy is from cardiac, from fundus or from pylorus or antrum. So again This is the cut open part of the stomach. G junction, above the G junction, this is the fundus portion. This is the body, here the antrum, and this part is connected to duodenum, which is pylorus. So here you can see this is the antrum, which is V-shaped area, and tip pointing proximally is near the distal margin, and proximal margin where the body and fundus having gastric fold. So you can identify these are the gastric folds in the body part. So if we see G junction, where esophagus and stomach are united with each other, having uh, 40 centimeter away from the incisor teeth, and here the epithelium of esophagus is squamous, where the stomach will have a mucosal lining, and it is converted into the gastric rugae. So this is called rugae. Now cardiac end is smallest region, poorly demarcated region, and extends 1 to 3 centimeter distal to GJ. And what is the clinical importance? Because this part is affected in Barrett's esophagus, cardiac carcinoma, and hiatal hernia. Now fundus, or upper portion of the stomach. So it is located above this J junction, contains air bubble and oxyntic glands. It produces HCl, intrinsic factor, and pepsinogen. So corpus is the largest part, and it contains oxyntic mucosa and major site for acid secretion, intrinsic factor, and pepsin secretion. Now antrum. So antrum is distal 1/3 part of the stomach, which contains pyloric glands, right? So here in the body part, oxyntic glands, here pyloric glands. So it produces gastrin and mucus, and this is the major site for H. pylori gastritis as well as peptic ulcer disease. Now rugae, these are the large mucosal fold. It permit expansion and increase surface area. It is prominent when stomach is empty but flattened on distension, and most obvious in the fundus as well as body part, but less obvious in the antrum part. Now another terminology, area gastrici. So these are the small polygonal mucosal areas separated by shallow grooves, and important fact is these are the permanent structure, and they do not disappear after stomach distension like rugae. Seen with the hand lens and appreciated in gastrectomy specimen, visible on barium study, double contrast barium study. So what is the difference between rugae and gastrici? So these are the temporary fold, flattened after meal, and grossly obvious. Whereas area gastrici, they are permanent grooves, never flattened, and seen on close inspection. So microscopically, if we want to see area gastrici, here you can see in low power view. These is section from the gastric oxyntic mucosa. Here these are the grooves. These are the shallow grooves. They are fixed groove, and area between this shallow groove is called area gastrici. So this is the fixed anatomical feature where uh, this is the area, dome shaped area separated by shallow groove. And radiologically, this uh, normal area gastric is looking like this is the having prominent dome shaped area, and these are the gastric rugae patterns seen radiologically. And in the laparoscopic view, you can identify gastric body showing these are the rugae or gastric fold. Now let's see stomach histology in detail. So basically it is having mucosa, submucosa, muscularis propria, subserosa and serosa. So mucosa contains epithelium, lamina propria and muscularis mucosae. Submucosa contains masonal or submucosal plexus, neural plexus. In muscularis propria, three layers of muscle are there, innermost oblique, then inner circular, outer longitudinal, and in between circular and longitudinal there is orbage or myenteric plexus. So here this is the low power view of fundus body area. This is the lumen portion lined by this mucosa. Beneath this mucosa, muscularis mucosae, submucosa, and this is muscularis propria, and this is the outer one is serosal lining. Now let's see mucosa. So it is divided into, first is surface epithelium. See here, this is the surface epithelium, and gastric pits or fovea. So fovea or gastric pits are nothing but the pit-like or depression-like area, and there is gastric glands, lamina propria, and beneath this gland there is muscularis mucosae. So basically surface epithelium lining the gastric fovea. This part is called isthmus. So beneath this pit you can see this is the isthmus portion, then neck, and this is the base of the gland. And we have seen three anatomical region, right? So the surface epithelium as well as this neck stem cells are common in all three regions, but all the three region will have a different neck and base gland areas. So we will see in next slide. So basically see here, this is the surface epithelium, this is the gastric fovea, right? So it is gastric pit, lamina propria in between the glands, this is pyloric glands, and this is muscularis mucosae. So three zone. So cardiac mucosa, main cells are mucus cells and secretion is neutral mucus. Whereas in fundus and body, which is called oxyntic mucosa, where you find parietal cells and chief cells. So it secretes uh, it secretes HCl, intrinsic factor, and pepsinogen. Whereas pyloric or antral mucosa, which is having mucus cells, G cells, and main secretion is mucus and gastrin from G cells. Now histologic transition, if we see, it is generally gradual transition from cardiac to oxyntic mucosa, and 1 to 2 centimeter wide area is there. Pyloric T oxyntic is also gradual, and there is mixed glands presentation. But from esophagus to stomach, it is abrupt change from squamous to columnar epithelium, and it forms Z-line, which is squamocolumnar junction. And significance is where you see Barrett esophagus, gastrointestinal reflux disease, and intestinal metaplasia. Now let's see some more about surface epithelium. So it is small, simple, tall columnar mucus cells. So you can identify mucus containing tall columnar cells with basal nuclei, apical mucin vacuoles, and it lines surface and gastric pit or fovea. So its function is it secretes thick alkaline mucus and protect against acid and pepsin. And if we go for PAS stain, it is PAS positive cells containing neutral mucin, and at the pH 2.5 Alcian blue is negative. And here along with this basally placed nuclei, you can see some of the lymphocytes with surrounding halo. So this is the formalin artifact, and these are the new lymphocytes, intraepithelial lymphocytes, which are normally present in few in number. Now this gastric pit or fovea, so it is lined by surface epithelium, and it receives secretion from gastric glands and protect glands opening. So this is the section from the pyloric mucosa, and here loosely placed glands, and you can see the half of the mucosal thickness is covered by these glands, right? And this is gastric foveola, and this is the pyloric gland. So this is the section from the pylorus. Now cardiac mucosa. So cardiac mucosa, it is immediately distal to gastrointestinal junction. Here the foveola is occupying one half of the mucosal thickness. So here you can see this is the mucosal thickness, and half of the portion is covered by this foveola, and half of the portion is covered by the mucosal glands. And in between this loose lamina propria, these are the mucous cells, and some parietal cells may be seen. Mainly neutral mucin is produced, and clinical importance is that this portion is associated with GRD, Barrett's, intestinal metaplasia, and sometimes carcinoma. Now pyloric or antral mucosa, which is the distal margin of the stomach. So here it contains mostly these are the pyloric glands. So here also gastric pits occupy around 50% of mucosal thickness. It contains long coiled mucous glands and abundant lamina propria. So here you can identify space between these pyloric glands. This is lamina propria, and it is secretion is neutral mucus. G cells are there which produce gastrin, and another cells which are present are mucus cells, B cells which secrete somatostatin, EC cells, enterochromaffin cells which secrete serotonin, and occasional parietal cells. So if we see in medium power gastric antrum, here you can identify gastric foveola, and these are the gastric glands, and this is muscularis mucosa. Now main portion of the stomach or body which is occupied by this oxyntic mucosa. So mainly present in fundus and body. It is having short pit, less than 25% of the mucosal thickness. So if we see this is the mucosal thickness, then gastric pit is having 25% of the portion, and rest of the portion is occupied by these long straight glands. And here there is closely packed glands are there. So here you can see surface epithelium, then mucous neck cells, these are parietal cells, and some of the stem cells are also present here. In the neck region there is parietal cells and zymogenic or chip cells also present, and the base of the gland contains zymogenic cells as well as endocrine cells. So oxyntic mucosa will have so many types of cells. So you remember parietal cells, stem cells, mucous neck cells, chief cells and endocrine cells. And mostly the surface peat is only 25%, whereas the remaining glandular structure is occupying 75%. So here you can identify these are the foveola, which is short, and these are straight long glands. And here also in glands you can identify two types of cell. One is darkly stained, one is lightly stained. So these lightly stained are parietal cells, pink in color, whereas zymogenic or chief cells, they are having purplish or dark purple area, staining. So chief cells, they are located at the base of the glands, basophilic in nature, basally placed nuclei. It is because of high number of rough endoplasmic reticulum and it secretes pepsinogen and gastric lipase. Whereas parietal cells, they are located in the isthmus and neck region. They are large, eosinophilic cytoplasm, centrally placed nucleus. It secretes hydrochloric acid, intrinsic factor, and what is the clinical importance? Whenever there is loss of parietal cell, it causes pernicious anemia, B12 deficiency, hypergastrinemia, and enterochromic cell like cell hyperplasia. So this is very important to remember different function of parietal as well as zymogenic cells. Now if we want to highlight the cell with the special stain, PAS stain, so in this oxantic mucosa, you can see the surface foveolar lining is intensely positive with this, whereas pale stain mucous neck cells are present beneath the glands. And these mucous neck cells are located at the neck region of the gland. They are PAS positive, but they are Alcian glue positive because it contains xylomucin, and the function is it is the stem cell compartment and associated with the mucosal regeneration. Now gastric stem cells. So already we have discussed it is in the neck region. They are differentiating into surface mucous cells, parietal, chief cells and endocrine cells. So stem cells, they are main cells for the generation of all the cells in the gland. And if we see cell turnover, to surface cells having lifespan of 4 to 8 days, parietal cells are replaced in 1 to 3 years, as well as chief cells also having lifespan of 1 to 3 years. Now endocrine cells. So G cells produce gastrin and it stimulates acid secretion. B cell, it is somatostatin hormone which inhibit gastrin. Enterochromic cell, it produces serotonin and it is associated with motility. And in oxantic mucosa, predominant cells are enterochromaffin-like cell, and it produces histamine and it stimulates parietal cells to secrete HCl. So if we want to highlight the endocrine cells, the IHC markers are chromogranin A and synaptophysin. So here you can see there are, this is the synaptophysin IHC stain, where in this oxantic gland you can identify scanty numbers of gastric oxantic glands, and here in this section this is the pyloric mucosa where you can identify numerous these endocrine cells which is stained by synaptophysin. So in the oxantic area, scanty cells whereas in pyloric area, abundant number of synaptophysin positive endocrine cells are seen. Now, lamina propria. So, lamina propria is in between the glandular mucosa, which contains fibroblast, inflammatory cells like plasma cells, lymphoma, mast cell, macrophages, blood vessels and neural supply. Lymphoid tissue, normally there are presence of primary lymphoid follicles and few intraepithelial lymphocytes, which we have seen in previous slide. But when you find secondary follicles with germinal centers, it is characteristic of Helicobacter pylori gastritis. So, whenever you suspect Helicobacter pylori gastritis, you look for secondary follicle with germinal center in the biopsy. Now, Muscularis mucosae, mostly two layers, inner circular and outer longitudinal, and it is having function local mucosal movement, and it helps gland emptying in stomach. So, this is how you can identify three and there are four anatomical region, but fundus and body will have this morphology, which is called auxentic mucosa. Cardia and will have this morphology, and in the pylorus and antrum you will find this morphology. So basically here 50-50% of gastric pit and gland, here 25% of gland surface epithelium and foveola, and 75% portion of gland in auxentic mucosa. Now submucosa, it contains loose connective tissue, blood vessels and lymphatics along with the major plexus, and it controls secretion and blood flow. Muscularis propria, three muscular layers, inner oblique, middle circular and outer longitudinal muscle. Now pyloric sphincter, which is formed by thickened circular muscle, and it regulates gastric emptying. So just to revise, gastric pits are long in cardiac and pyloric region compared to the glandular mucosa, whereas in auxentic it is short compared to the glandular mucosa. Glands here coiled, here straight glands are there. Cardiac having and pyloric having mucus secretion, pyloric having gastrin secretion, where auxentic glands will have acid and pepsin secretion, right? Lamina propria abundant, but here it is scant in nature. Major mucus cells, mucus plus G cell, here parietal as well as chief cell. So summary, surface epithelium, which is simple columnar mucous cell, pass positive neutral mucin is there. Chief cells secrete pepsinogen, parietal cells which are eosinophilic, it secretes HCl and intrinsic factor. G cell, gastrin, D cell, somatostatin, ECL, histamine, next cell, it is stem cells. Turnover surface epithelium 4 to 8 days. Meissner, which is associated with secretion and in submucosa. Orbic plexus associated with motility and it between muscle layers. Secondary follicles suggest H. pylori gastritis, and three smooth muscle layers of stomach, inner obliques, middle circular, outer longitudinal. Now, if we see ultrastructure of gastric mucosa, so surface and foveolar epithelial cells, they are containing numerous electron dense mucin granules, and short microvilli contain moderate rough endoplasmic reticulum, few mitochondria, and there are two types of cell junction in between. One is tight junction called zonula occludens, which prevents back diffusion of HCl pepsin because all the cells secrete HCl and pepsin. So itself, this HCl, if damage to stomach, then to prevent this, we require this junction. Then adherence junction or called zonular adherence. So it is mechanical attachment between adjacent cells. So what is the clinical importance? So whenever there is damage to this tight junction, there is possibility of either H. pylori infection, NSAID induced gastritis, ethanol injury, bile reflux, stress related mucosal injury, because whenever there is loss of tight junction because of all these factors, there is increased acid back diffusion which lead to injury and ulceration. Now if we see light microscopically, this is having large polygonal and eosinophilic cell, centrally placed nucleus, and resting cell contains microtubules. It contains numerous mitochondria, and here tubulovascular fuse and form the membrane surface for it increases the membrane surface area for acid secretion. So basically parietal cells are highly eosinophilic or intensely eosinophilic because of thousands of mitochondria, and it is containing numerous intracellular membranes. Now if we see mechanism of acid secretion, so hydrogen ions are actively transported by hydrogen and potassium ATPase proton pump across the canalicular membrane into the gastric lumen. So proton pump inhibitors which we are prescribing like omeprazole and pantoprazole inhibit this proton pump or uh, hydrogen and potassium ATPase pump. Now cheap cell ultrastructure. So if we see cheap cell, it is containing abundant rough endoplasmic reticulum. It contains prominent Golgi apparatus, secretes pepsinogen and gastric lipase, and because of a high number of rough endoplasmic reticulum, it is basophilic in nature. So surface cells, parietal cells and cheap cells, main secretion in surface cell is mucus having short microvilli, few mitochondria, moderate endoplasmic reticulum, mucin granules and cytoplasm is pale. Whereas parietal cell secretes HCl intrinsic factor, numerous microvilli, very abundant mitochondria and eosinophilic cytoplasm. Cheap cells which secretes pepsinogen, few microvilli, moderate mitochondria, abundant rough endoplasmic reticulum and zymogen granules. So it is staying basophilic in nature. Now how the regulation of gastric acid secretion is done. So first is neural control. It is via the vagus nerve, and this vagus nerve lead to acetylcholine stimulates parietal cells. It also stimulates G cells. Second control is hormonal control. So G cells located in the pyloric antrum, it stimulates gastric distension, amino acids and peptides, and it stimulates parietal cells via ECL cells, and this ECL cell lead to release histamine. Another control is paracrine control, where enterochromaffin like cells produce histamine which acts on H2 receptors of parietal cells, increase acid secretion, and D cells. This is producing somatostatin and it inhibits gastrin release, inhibit acid secretion. Now, what is the function of HCl? So, HCl activates pepsinogen, which is converted into pepsin. It denatures proteins, facilitates iron absorption, helps vitamin B12 release from food, kills microorganisms and maintain gastric sterility. Now, something about gastric mucus. There are two types of mucus, soluble, insoluble. So, soluble mucus produced by gastric glands, function is lubrication, whereas insoluble is produced by foveolar as well as surface epithelial cells and its function is protection. Now, histochemistry, if we see surface and foveolar cells having neutral mucin, whereas mucosal neck cells contains neutral xylomucin and sulfomucin. Now, if we want to confirm a different mucin immunohistochemically, we require Muc5AC for surface and foveolar epithelial as well as mucous neck cell. Muc1 for surface, parietal and cheek cell, whereas Muc6 in the antral gland and mucous neck cells. So, what is the diagnostic importance? This aberrant mucin expression, different mucin expression helps to categorize gastric dysplasia, metaplasia and adenocarcinoma. So, gastric mucosal barrier which protects the stomach from self-digestion, which is very important, and it consists of, this barrier consists of, one is mucus layer, second bicarbonate secretion, surface epithelial cells, tight junction which is zonula occludens, adequate blood flow and prostaglandin. So what is the role of this prostaglandin E2 and I2? It increase mucus secretion, increase bicarbonate secretion, improve mucosal blood flow, it promote epithelial repair and reduce acid secretion. So what is the clinical relevance? Whenever we prescribe NSAIDs, it inhibit cyclooxygenase and lead to decreasing prostaglandin synthesis and which lead to gastric erosion and peptic ulcer. So NSAIDs having a role on the prostaglandin synthesis. So points to be remembered: zonula occludens, main barrier, parietal cells contain mitochondria and intercellular canaliculi, chip cells having rough endoplasmic reticular and zymogen granules, hydrogen potassium ATPase, it target of proton pump inhibitor, histamine from ECL stimulate acid secretion, somatostatin from D cell inhibit gastrin and acid secretion, surface epithelial mucus is neutral mucin, Muc5 is a marker of surface foveolar epithelium, Muc6 is pyloric gland and mucous neck cells. And the gastric mucous barrier depends on mucus, bicarbonate, intact epithelial with tight junction, blood flow adequacy and prostaglandin. So, understanding normal gastric histology is the first and most important step toward diagnosing gastric pathology. Once you can confidently identify the normal architecture and the different cell types, recognizing abnormalities becomes much easier. So in our next lecture, we will build on this foundation and begin exploring gastric pathology from gastritis and metaplasia to dysplasia. And if you found this session helpful, please like the video, share it with your friends and colleagues and subscribe to the channel so you don't miss the upcoming lecture in our histology for histopathology series. And this is the reference from this book. I have made this lecture, and in our next topic we will see some special techniques, artifacts and differential diagnosis of gastric biopsy. So thank you for watching, and remember, no normal to diagnose abnormal. See you in the next class.